Hello, everybody. This is Hooman Sadri. I'm a professor at Wake Forest University in Winston-Salem, North Carolina. I'm a male reproductive urologist practicing and helping people with infertility issue in the past over 20 years. And I practiced in different locations in North Carolina. In addition to my practice, I have an active research lab on male reproductive and fertility, which is at Wake Forest Regenerative Medicine Institute. I appreciate the invitation and this opportunity to overview the state of fertility in our X and Y chromosome variation members of our society. There's no disclosure and conflict of interest for this talk. I'm going to talk actually about the infertility in general in all population, because it's good to know that a lot of people are dealing with this. We focus specifically on our group of patients, and then also we go as much as we can through the current clinical options to treat infertility and potential experimental option that we hope to be available in the future. I'm a clinical andrologist, and I'm practicing over 20 years on a male reproductive medicine and helping people and with different reasons to have difficulty to have kids. And probably the word of andrology is not as familiar as gynecology for many of you, but it's very equal to that. And these two actually in combination are very important to help people to have a healthy reproductive, condition. There's some terminology that it's good to know. I mean, when we are talking about the fertility in general, we are talking about the conceive or inducing pregnancy. There's some terminology, other terminology like fecundity, that it's mainly talking about something ended to the live birth. Infertility, by definition, it's called when a couple are trying to conceive for at least 1 year without using any birth control. And if this happened, without any previous, history of fertility, it's the primary infertility. And if they had history of having a child together, then this will be a secondary, which means they were able to have a pregnancy and a live birth in the past, but not for the second part and in a new trial. Infertility is quite common in the general population. Almost 1 out of every 6 couples experience infertility. And it could be because of some issue on a female or male or both. And as you can see, it's quite common in both gender. It's not just focusing on one. And it's a lot of people, in the United States and worldwide are dealing with infertility. And of course, when we are talking about the fertility, we are talking about a couple, not just one single individual. And that's why, it's really complicated to see and, what's the condition, what's the option, because we have to really at the same time look at the both male and female partner. The classification of the reason for male infertility, it's dependent on where and which part of the body is involved. Of course, the reproduction, either in male or female, it's controlled by the brain and the gonads around the brain, mainly pituitary gland, and it's goes down all the way to the reproductive area, which in men will be testicles and all relative organs. And depending on the issue in each level, patient has a different, condition, and that we approach and we can help the patient based on that. As you can see in this slide, there are different reasons. It could be, some abnormality on like a varicocele, which is a diluted vein, which is quite common, infectious, hormonal, ejaculatory. But as you can see, one of the major, reason is the genetic, which is the main focus of our society, based on, the patients are supported in the condition that they have. And you can see something around 8% of the people in general are dealing with this issue from the whole population of infertile people. The first thing on male, when we are having adult patients, to have an idea, is actually look at the semen and see how is the sperm production. And usually, we ask the patient to have a 2 to 3 days abstinence before collecting the samples. The techniques, how to collect, is quite important to be sure the patients collect everything, especially that the first part of the collection has much more sperm usually. And if one sample is abnormal, we never, rely on just one, and always should be repeated, not immediately, with a good time after that, usually after a few weeks. World Health Organization during the years had different reference value for the normal number of sperm. As you can see, this is kind of the trend, and we had it recently, updated. There are actually numbers about, the volume, the sperm count, the swimming part, which we call them motile sperm, and of course, look at the normal shape of sperm. And this, being under this doesn't mean that people are not able to do it, but this is kind of, a average number, and based on that, we kind of, look at and approach people. And as you can see in this, even in one single person, the number of sperm goes really up and down during the year. This is from one, individual that, dropped the samples during a long, 120 weeks, and you can see how the numbers change, which means, the fluctuation is quite normal. And that's what also another reason that we never rely on one sperm count. When we look at the female, it's a little more complicated, but, because there are actually, the connection between the ovarian, which is the source of the eggs, and also, the transportation for those, and the way that when the sexual activity happens, sperm meet eggs and the embryo will be formed. And then any issue on the whole system, including out of the pelvic and genital area, also can affect the female fertility. And that's why, based on the level of the issue and, the infertility in the female can be caused, with different situation, and of course needs a different approach and treatment. If we focus on the genetic part, there are three groups of people that I'm going to focus on this presentation. Of course, the triple X, the Klinefelters, typically, XXY, and also some other, type of the variation on the male patients in our cohort, which is the XYY or Jacob syndrome. There are some other variation, but the approach is quite, similar for, the male variation, and it's not much difference. But of course, the prevalence is different for different type of those. This is a example of the karyotype, which is actually the test to look at the chromosome numbers, and and this is a normal male karyotype with the 46 chromosome, including the somatic chromosome and a 2 X and Y, the sex chromosome. Of course, for the Klinefelters, the number of, the chromosome is different. Initially, Dr. Klinefelter, who was practicing in Virginia, described Klinefelter as the endocrine specialist, and he didn't know actually anything about the genetic background of this people, but later, in a couple of years, almost 17 years later, the genetic was described, and the chromosomal, change was found. The prevalence is 1 out of 500 newborn, and it's quite, it's the most common sex chromosome disorder in men. It's the most common genetics cause of male infertility, and more important is, a lot of these people, they don't know it until they're trying. Even if they know, earlier, it's very important because despite other genetics, these people have almost normal, life expectancy. And to be honest, when I talk to my patient, I tell them I don't call this is a disease. It's more a variation to me because it's quite very common. Everybody has some issues, needs some help, and I believe these people needs help too. But to me, it's more a variation other than a pathology or a disease. And that's the way I think we should look at the Klinefelter, and the same for XXX. This abnormality, or, the error on the chromosome number, it may come either from, egg or sperm. And there is a way to distinguish that it's coming from which one, but there's no reason because it doesn't change, the plan. But it's good to know that it's not something that always comes from egg or a sperm. It could be either one. As I mentioned earlier, the typical Klinefelter, they have extra X chromosome, which is 80-90% of our patients, but there's some other variation with more extra chromosome and different pattern. But the interesting and important thing is even our classic 47XXY are not classic, which means we see a lot of variation on any aspect, including infertility and, make a sperm. That's why, a lot of effort is doing on learning more about why there are more sub-variation and, the differences. But our approach to help most of them usually is not, much difference. What happened on Klinefelter patients, they actually have usually, everything normal and a normal level of testosterone as a newborn, baby, and also until around the puberty time. And the puberty also in most of them initiate normally, but gradually it fails and has some issue because it's not going on the same way that expected. But again, we see a variation on people. There are people that they pass the puberty not much different to normal people. So that's why, I told you the classic Klinefelter is not really classic. And there are also difference in this aspect. The testosterone level, usually, during the life, and there will be a faster decline that every man usually have after the age of 28, which we call it andropause. But in this patient, it's most likely that this decline happened earlier and they need some help earlier too. The hormone levels, including testosterone and hormones that control the testis function through the pituitary, which is a follicle stimulating hormone, or FSH, or luteinizing hormone, or LH, which are producing from, pituitary gland, are, changing on this variation. But again, in general, what happened, testosterone goes gradually lower, and then FSH and LH goes higher, initially to compensate the testicle to produce more product, including testosterone, and if they do, sperm, and gradually this may actually happen. That goes higher, which we believe that there's kind of progressive on a fibrosis or dysfunction of the testicle. The sperm production needs, the stem cells for sperm from the germ cells, that, the process is not going to be normal in most of the tubules of the tubes on which are the place for producing, the sperm in the testis. But still, in many of the patients, we can detect rare areas of sperm production, which is quite promising. And the same issue related to the testicular, function, the testis size, which normally for any a newborn boy is quite small, and there's no much change until, the puberty. It's going to increase, but not as much as expected, and stop, in a mid-size. And that's why, actually a lot of these patients are recognized if a good physician see them and examine them earlier, and found, around the puberty or a little after that to be, concerned and have the diagnosis based on this. Of course, there are other ways that the diagnosis happen these days because of a lot of genetic tests is done. The puberty is kind of a critical time, for many reasons. It's quite important to, know before that. If we know, because we can actually help these patients, we can help them for some preservation option. We can also know about their need about testosterone earlier or later, which it's quite, important. And that's why it's good to know it earlier than later and then help these patients. The testosterone treatment, which I'm sure there are some other sessions specifically talk about this, it could be in general for any person who needs it with different benefits, because for the general, growth, or muscle mass, or, bone density, for a lot of, sexual characteristic, and also psychological, benefits out of testosterone treatment or replacement when it's necessary. And of course, older people for sexual activity, libido, desire, and also the performance is quite important. The most important thing that a lot of physicians, unfortunately, they don't know, even the urologists, that based on the existing survey, that they think that giving testosterone help people to be more fertile. But that's not true in most, because giving testosterone is like giving somebody, a lot of free money. What the person does is stop working, because then become lazy. That's the same things for testicle. And that's why, we have to be careful if we are thinking about the long-term fertility, or even for people that they're trying that, we have to help them in a different condition. There are some alternative and options that instead of shutting down the testicle, still we can keep them active. A lot of them could not be a good option for older Klinefelter patients because the body already compensated, have a high level of FSH and LH, but still in some cases using medication like HCG, clomiphene, or anastrozole, letrozole. These are the one that, we may use sometimes to advance the puberty or help them initially, but not maybe longer time. And in some cases are helpful. A very, very interesting and exciting new medicine, which is in the market after FDA approval, is a nasal testosterone, which can change actually the concept of using testosterone in people with the fertility desire. It's it's a non-invasive way of using it, and but it's quite frequent application, which based on the FDA approval, it says 3 times a day. But we have some patients, we can do it two times a day, because everybody's metabolism is different. But in general, this very frequent and short half-life, we believe it's actually helping what the data shows in 2 limited study that in general, the men that are trying to conceive, when they have been on this testosterone, over 85% of them, there was no change on their sperm production. Still, it's important to approach every individual carefully, because it's still, 15%. It was shown that, there are some changes, but, by looking at other hormones and in sperm count in specific cases, we can actually, monitor the patient before being long-term on this kind of medication. But quite, interesting and a new way of, helping our patients to improve their testosterone level. For looking at, the fertility preservation and, how we can help these patients, like what I do in my clinical work is actually depend on the age of the diagnostic for the Klinefelter. Personally, I see patients that they went through the IVF, the couple, and they have an embryo diagnosed as a Klinefelter. They come to me to ask what to do and what will be the future. I have pregnant women that, they know they have a Klinefelter, and they come and ask. And of course, the parents with a Klinefelter child in different age, they come and we discuss the options and we explain to them what they need to know. For evaluating a person, as early as we see, we kind of, examine and we look at the testicle size, the other, the pubic hair, and the size of the penis, and we have a staging, we call it Tanner stage, that, we monitor this patient, especially when we see them from the earlier stage. Usually I'll try to see every year, and then when we are around the puberty with a shorter interval, at least, every 6 months. And we have some other tools that we can look at, the change on the testicle, very non-invasive, using a special, ultrasound, which can measure the stiffness and shows the progression of the fibrosis, which is more common in testicle of Klinefelter people. Depend on the age, we have different approach to, preserve something for them, that, before going through a long-term treatment that may affect, again, because of new product, like we just talked about the nasal. We may actually try to be less invasive and go, more natural with these patients. But, there are other options that, we can offer. Some of them are still experimental, and we have to be very careful when we offer it to the patients. They understand that is not a standard treatment. But usually if we have a patient with around Tanner 3, we expect that, there could be a chance of, started making some sperm in general. If we have a patient mainly in an older age, and they're trying to conceive and we don't detect the sperm in the ejaculate, which more than 92% of the Klinefelter patient, we don't expect to see any sperm in the ejaculate when we test even more than one time. The gold standard is use, the technique calls microscopic testicular sperm extraction, or micro-TESE, which, we can, under the operation, when the patient is sleeping, we can actually find a nice area of the testis that most likely there are rare sperm production, and we can use those. Of course, any sperm can be harvested in this way. The only way we can use is in vitro fertilization, which was a revolution, happened, initially by just traditionally put the sperm next to the egg. And then in 1991, another, biggest step happened, which describing a method of injecting a single sperm to the egg, which helped to use even non-moving sperm called ICSI or ICSI. And latest, systematic review and meta-analysis, specifically for Klinefelter patients, based on looking at the different report from different clinics worldwide, shows that around 44% chance of finding a sperm on Klinefelters expected, and overall, live birth rate is around 43% too. But of course, there are some centers with a higher, some centers with a lower. But I can tell you, if a center has a good setting, they know how to approach these patients, that they can increase much this percentage. But this is overall, which is quite promising. And of course, although interestingly, we know that a Klinefelter patient, when we find a sperm, the chance to have a child with the same genetic variation is not interestingly higher than general population, which means then the percentage of normal sperm are the same as other non-Klinefelter patient. However, because we are dealing with testicular sperm and some kind of general risk, we really recommend to test every embryo before using for genetics, which called pre-implantation genetic diagnosis, which can be used for many other patients too. As I mentioned, there's 44% based on the literature review and meta-analysis chance of finding a sperm. But what about the people that the microtesting will happen and there's no sperm? The sperm produced by his father, which is a spermatogonial stem cell, and everybody is born with that, not with the sperm, and then later have it. As you can see, there kind of older data shows that in the younger patients, the chance they have the spermatogonial stem cells, it's higher than older. And that because of the progressive fibrosis, trend on Klinefelter testis, that they usually, they gradually lose the stem cell, which is important to produce a sperm later. And you can see in these pictures that how from the stem cells to the sperm, goes. And this process usually happens when they have the stem cells, after puberty, step by step, the differentiation happen until having the full sperm. And as I mentioned briefly, spermatogonial stem cells, which in abbreviation we call them SSC. Everybody has it when it's born, and then later at the puberty they differentiate to the sperm, which is around the age of 10 to 12. Could be different in different people based on the the area they're living and some family background and a lot of other factors, but roughly is around 10 to 12 years, the time that the sperm production from SSC started. And it's quite important to think about it, because the main reason that the Klinefelter has, most of them in an older age, they don't have a sperm in the ejaculate, and if they have this in a rare area is, we don't know exactly why, but they're, having a normal spermatogonial stem cell at the time of birth in their testicle, but gradually, and specifically after, puberty, these numbers going to be down and quite become rare, quickly, even, after a few years after, the puberty is started. And that's why, the percentage of finding the spermatogonial stem cell in the younger shows is more common. We did actually a new study that we published it, and we look at actually, and we use the different methods. We could identify actually more spermatogonial stem cell on Klinefelter patients than before, because we use a specific marker. Traditionally the pathology lab, they just look at the regular staining, which was the hematoxylin and eosine. And when we actually did, we could increase the detection rate to up to 72%, which is more than what you did. And this is basically on an adult, older patient. And then you can see that still, by using a special marker, you can actually detect very rare number of, spermatogonial stem cells, even in older patients. And of course, again, we did another study, and that we showed, although, in an earlier age, most of the Klinefelters, they have the spermatogonia, but, when they become older, this percentage will be less. And that's why, when I see a patient, I tell them this trend, but I'm not pushing them that we have to do an invasive surgery to preserve the stem cells, which we know in an earlier stage. But one of the advantages of making a relationship with the parents, with the patient, is if the patient needs to go, for example, through a standard procedure like a hernia surgery, and he's already my patient, they let me know. And a lot of time we can actually, arrange it under the same anesthesiology without extra risk, because the main risk on children is the anesthesiology risk. The surgery is quite, non-invasive and quite, safe, or less invasive, probably, as it is. Still, any surgery is invasive, but less invasive than many other operations. But we don't want to put them at risk of, anesthesia for something is not a standard treatment yet, but although we know that it gives more hope for them for new methods, for especially people that they do not produce a sperm. But then they will contact us and we can arrange with the surgeon who is doing the standard treatment to have something, together. And of course, the idea of preserving the spermatogonial stem cells or finding is to use it for the method that experimentally is still, it's, people are working, including my research lab and, other groups, that we hope, we can increase the number of this, spermatogonial stem cells, because the number is quite rare on these patients when we get it, and also use it even to make, a sperm in a dish in the lab and use it for IVF, or by putting back to the body by transplantation and reproducing or producing more sperm. Because of that, over 8 years ago, I established a banking system, not only for Klinefelters, mainly actually for the pediatric cancer patient, and you can see, and some other patients with testis abnormality. And so far, you can see, in one center, which is the Wake Forest University, we had over 200 patients that, part of them were specifically the Klinefelter patient, and almost 70% of the, parents and patients that it was offered, they agreed to go through the biopsy and preserve testicular tissue, including a spermatogonial stem cell for future experimental work. A very, very important step that we just could get it was actually we could develop an in vitro system to increase the number of spermatogonial stem cells from a Klinefelter patient, because as you learn, from my previous slide, we're dealing with a very low number of spermatogonial stem cells, but we could find a method, and we publish it, that we can at least increase their number as in a very good amplification rate, which is an important step before the next step, either making the sperm in the dish or transplantation. For the female part, and our triple X patients, again, this is a karyotype of a female, normal female, that you can see 2 X chromosome, and of course the same number of somatic chromosome, the same as men. And when the number of chromosome is for X is 3, we call it triple X syndrome. And this was actually described the first time in a girl in 1959 in Scotland. And that was a person that actually, the reason they focused was the girl actually had a premature ovarian failure, which is like a menopause, but very early at the age of 19. And that's she was born from a little older, parents, and the later, and we know that this may happen when the parents are older, which is quite common. People postpone fertility these days for different reasons. The triple X syndrome is, less common than Klinefelter, but still quite common. 1 in every 1,000, female born, and it's the most common sex chromosome abnormality in female. Most individuals with 47XX are diagnosed incidentally because, with the prenatal genetic screening, the same as, other things. And interestingly, although the phenotypes is different, the same as, Klinefelter, usually, their height is, higher than the percentile, but a lot of these, actually, they do not have a much different problem with the puberty and fertility. And even, if a lot of them maybe, have normal children, and they could conceive normally because they tried in an earlier stage. And again, there is a variation between this group of patients too, but in general, the most important thing is they should be fertile, but the premature ovarian failure may happen not as early as the primary case was, reported, but earlier than, the age that expected. And the premature ovarian failure in general is not quite a common thing. It's quite 1% of all women, but in this patient could be, more common, and that's why when somebody has, some hormonal issue and even they don't know genetics, that's one of the things that they have to check. And there could be some way that this patient, we can help them. In summary, the infertility, it's a common issue in general population, not only important XXY or Klinefelter patients or triple X, which is less common, as I mentioned. And more than 98% of Klinefelter patients, they're dealing with this, and very few of them, I have patients that, was having a child, especially when have a younger, partner naturally because they had some sperm, but most of them are dealing, with infertility. And there are some techniques and the way that we can help them before putting them on testosterone. There's some new testosterone treatment that we talked about it. And of course, when we're searching for a sperm, the techniques of microtesting and AXY are, the big advantage of helping these patients. And the spermatogonial stem technology is the new tools that, still experimentally, should be looked, and we hope that we can use it in a, near future for more patients to help them for fertility. And for the triple X, as I mentioned, we're not worried as much as the others, but it still is good when somebody knows, have a physician that can follow up and monitor the reproductive health of this patient, and just when some sign of ovarian dysfunction starts, and they can evaluate the egg reservation, and also if the patient wants to postpone, pregnancy, there could be some option like egg freezing that can help them. And then, before, they enter to the premature ovarian failure. I hope this quick, overview for male and female patient can help you. There are some contact information for people that they need to be seen in person or virtually, and we hope we can help them for fertility. And I'm happy to answer any question.